here. So maybe Mitra, you may want
Sure,
to handle that.
absolutely.
Okay.
Are you able to see that okay?
Yeah, I can see that. Okay.
Excellent.
So the topic I'm going to be reviewing today is a fairly new in the field of pulmonary critical care, a kind of intersection of two fatal disorders, both of which are underdiagnosed and underrecognized. So I thought that this would be a good time to review some of the advances in there. And I'm going to be talking about the interstitial lung disease, which I believe all of you are very well familiar with, considering a lot of coal miners' disease and other pneumoconiosis that we see often in Appalachia and West Virginia area. Next, please. Yeah. So we're going to start with a case, 62-year-old woman with progressive history of, no history of smoking, but lung disorders with worsening shortness of breath over the last 6 months and dry intermittent cough. On the right-hand side, you can see a preliminary scout chest x-ray of this woman. And I'm pretty sure none of you are surprised at seeing some of this interstitial markings, bilaterally diffuse, somewhat lower lobe predominant, and very quintessential of an interstitial lung disease that we often see here in Appalachia. So I think the first reaction we all have to this is, well, she's got no history of lung disease, no prior problems. Why can't this just be a viral infection or a bacterial infection? Let's just treat her with some antibiotics, steroid course, and see what happens. And that's what happened in her case. She was treated with a round of antibiotics and got somewhat better, and then it came back again. And by the end of 6 months, she had already had 4 courses of steroids and antibiotics. So again, not an unusual story for many of us in this region. CBC and chemistry profile was done, and none of them was remarkable. Next slide, please. So based on this scenario, what would you do next? And what would we do? Well, I think that at this point, most of us would agree that a 5th course of antibiotic and steroids probably not the best idea. And would you order a CAT scan of the chest and pulmonary function test? Or would you go to the MRI of the brain? Consider smoke cessation? Well, everybody should have smoke cessation counseling that goes irrespective of any patient who's either symptomatic or not. I think MRI of the brain obviously would not be an appropriate test in the setting. So we should go and further evaluate what's going on with this woman and see if we can find some more clues on a CAT scan and some PFTs in this lady. So next slide, please. So this is one cut from her CAT scan. And I think even to a discerning eye, you can see there's significant amount of scarring, interstitial infiltrate, maybe some subpleural honeycombing. You can see some bronchiectasis. So looks like a chronic damaged lung, very consistent with interstitial lung disease. As we had promised, we even got a PFT done, and you can see that there is a TLC of 65%, which is suggestive of an interstitial or restrictive process. What is interesting, though, is at least from numbers, TLC of 65 suggests a moderate interstitial lung disease, but the DLCO, which is the amount of oxygen being transferred from your lungs to your body, is very, very low at 30%. So almost seems like out of proportion drop in diffusion capacity compared to the pathology that is seen on the PFTs. Incidentally, she also had an echo, which showed RVSP of 50 millimeter mercury, which, by the way, is a surrogate marker for elevated pulmonary pressures. So next slide, please. So great. So we now know, based on the CAT scan and the PFTs, that this patient has interstitial lung disease. And we know that that holds a bad prognosis. Fortunately, in the last few years, there's been dramatic improvement in our understanding of interstitial lung disease and also some therapeutic options which were not there before. So as most of you are aware that we have FDA has approved 2 antifibrotic agents in the last few years to reduce the amount of fibrosis. And if you look at the data published in New England Journal and others, you'll see that it slows down the decline of lung function over the year. So not necessarily a big step, but a mini small step in the right direction of slowing the assault on the lungs from this deadly disease. However, there's some recent data come in, which is basically in form of registries, which is showing that there may actually be mortality benefit, that these patients may be surviving more now than they used to do before. So having said that, there's a new entity which has come to light, which I'm going to be mostly focusing on in this hour in ILD, which we weren't aware of before, is the presence and the impact of pulmonary hypertension in these patients with interstitial lung disease. So one telltale sign on a chest X-ray or CAT scan that the patient may also have an underlying pulmonary hypertension with interstitial lung disease is the size of the pulmonary artery. If your size of the pulmonary artery on a CAT scan is larger than the adjacent aorta, that should be a clue that there's something more wrong with the interstitial lung disease than just a plain simple old disease. Next slide, please. So the talk today is going to focus as ILD is already bad. We have very little options. We just got some 2 new medications, which hopefully are slowing down the process. Now, what is this new thing which is coming in the ILD? Well, it is the pulmonary hypertension. So one, how do we know that the patient has pulmonary hypertension? What is the impact of pulmonary hypertension? That's all we're going to be reviewing today. Next slide, please. So now switching a little bit of the gear from interstitial lung disease to pulmonary hypertension. Typically, there are 5 groups in which pulmonary hypertension is divided. Pulmonary hypertension, by the way, is like an umbrella term, and it has 5 entities within that umbrella. So traditionally, as pulmonologists, our focus had been on group 1. Why group 1? Because this is the pulmonary hypertension which is most fatal. So, once diagnosed, the mean survival was about 2 to 3 years. So not a happy situation. And the other reason why we were focused on that was that there are 12 FDA-approved medications now to treat these group 1 pulmonary hypertension. The only other group which any treatment option is available is group 4, which is the CTAF. Now, don't get me wrong, the treatment or gold standard treatment for CTAF or group 4 still remains surgery. But if surgery is not an option, then there's an FDA-approved medication called Adempas or Rioxyguad, which is available. But apart from these 2, the rest of all the groups, there was no treatment available except treat the underlying cause. So whether if you look at group number 3, which is mostly lung diseases, whether it's COPD, interstitial lung disease, sleep apnea, alveolar hyperventilation, there was nothing we could do about pulmonary hypertension but to recommend, hey, be aggressive in treatment of the underlying disease and hope and hope that pulmonary hypertension gets better. Same was true for group 2, treat the left heart disease, treat the systolic dysfunction, diastolic heart failure, and hope that things will get better. That has started changing. And that's a big, big radical change, because there's been 20 years of research, and no matter what we did, we couldn't break through this very, very difficult groups 2 and 3, and we had very limited option. But recently, there have been trials which has shown that interstitial lung disease, the one I was talking earlier about, if that is connected with pulmonary hypertension, then maybe there's an option to treat that and maybe change the outcome. So a big first in the field of PH. Next slide, please. All right. So then the next question comes in is, if you are worried about pulmonary hypertension in the world of interstitial lung disease, then the first intuitive question is, what's the prevalence? If you're telling me there's 1 person out of 200 who may have pulmonary hypertension, well, it's important because it may impact outcome, but I don't think it's going to impact everybody. And it is probably not that important from community point of view. But if you look at the prevalence on this slide, you'll see prevalence ranging anywhere from 20 to almost 80%. It's a wide range. And you may wonder, why is such a wide range over there? Well, it depends. First, it depends on what is the modality or testing modality that you use to find pulmonary hypertension. So if you look at the blues, these are all transthoracic echocardiograms, so kind of like an ultrasound of the lung. That's how they found out the pulmonary hypertension. The ones in the black bar are actually right heart catheterization, where they actually go inside your heart and measure the pressure. So depending on what testing you used, the prevalence obviously going to be different. The second thing is that it is not a static disease. So depending on which part of ILD you catch or test these patients, your prevalence is going to change. For example, if you look at the studies which show 80% prevalence, which means pretty much everybody having, are the patients who were undergoing evaluation for lung transplant. So they were so advanced interstitial lung disease that they're going to a center which does lung transplant, and by default, all of these patients have to have right heart catheterization to characterize their hemodynamics before the transplant can take place. And once you do that, you find that 80% of them have it. So the prevalence is very wide, but even if we took the most conservative numbers, and let's say we take the lowest one, we don't believe anything else, 20% is still 1 in 5 patients with interstitial lung disease having a fatal combination with pulmonary hypertension. Next slide, please. So a little insight about the pulmonary pressures. Now, this has been a moving target. Many of you who are familiar with the pulmonary hypertension world understand that every 4 years, a group of experts meet together and then redefine the disease, the diagnostic thresholds for that. And until recently, it was 25 millimeter mercury of pressure and higher was termed as pulmonary hypertension. But this is an interesting study done in the VA where they analyzed 21,000, in fact, a little bit north of 21,000 patients, and looked at what elevated pressures inside their pulmonary vessel meant to their prognosis. So on the x-axis is the mortality, on the y-axis, and the x-axis is the pressure. And you can see that the graph starts taking off even before 20 millimeter mercury of pressure. So that means that people start dying very early in the process, even when the pressure has not even hit 20, and you can see that trajectory going up and up after that. So a lot of us felt that that 25 millimeter mercury cutoff we are kind of missing out all of these patients, and some of these patients may be dying even before we get to the diagnosis. So there was a radical change in our thought process and say, well, I think we need to change the definition. We are missing out on all these patients here. And if you see the recent reclassification of the diagnosis, they have changed those numbers now from 25 to 20 to accommodate for this new reality that people are dying, and we were missing it. The next slide, please. So there's another important factor if you view the landscape of PH-ILD, is that if you look at the PH-ILD, and as I just alluded to you, as much as 80% of these patients could have pulmonary hypertension hiding and causing them to die sooner than they would have done before. Look at the pressures in almost majority of these patients with interstitial lung disease. They're not too high. So although they are dying, but their pressures, if you look at that, majority of them, they hang around 20 to 30s. So the bars, you can see the highest bars are at around 20 to 30. So it's not like they are busting their pulmonary vessels at 80 or 90 pressure before they collapse. They're dying at very low pressures. And on the right-hand side, you can see that just the presence of pulmonary hypertension dichotomized these patients, whether they're going to have a bad outcome or good outcome, having everything equal in the interstitial wall disease. So it became important to focus on interstitial lung disease and pulmonary hypertension, because it seemed like this was a bad vortex of death, and the combination of the two was really putting the patients in a very disadvantageous position. Next slide. And lo and behold, if you look at some of the data coming from Washington, D.C.'s group from Letary and others, you can see that these patients, now remember that these both groups are same. Both have interstitial lung disease, similar degree of interstitial lung disease, but one has PH, the other doesn't. That's the only difference. And you can see that those people who have PH cannot even walk too much. So their 6-minute walk distance is only 144, which is half of the patient who did not have pulmonary hypertension. Their oxygen comparatively remains quite low, and their mortality, or the degree of the death in that group, is almost double of the ones who did not have pulmonary hypertension. So not only the outcome in terms of mortality, but also the morbidity, how much they are suffering, both of them are contributed by pulmonary hypertension. Next slide, please. So the big theme, which I'm going to keep recurring and alluding to in this, is that while we have latched on for many years as echocardiogram being that screening test, it may or may not be that helpful or true. So that is kind of the underlying theme which I wanted to start giving them as a message to the group, and keeping the talk focused around that, so that we understand what are the clinical key points or pearls that I'll get out of this particular lecture. So starting with this slide, you can see this CAT scan. Horrible. This is not the same patient which I showed you before. This is a completely alien picture, but you can see horrible lungs, significant damage from interstitial lung disease. You can see a lot of honeycombing, bronchiectasis. So definitely looks somebody who's got advanced interstitial lung disease. But now we are trying to focus our eyes on a different area, not the lungs, but the mediastinum, right in the center. You can see those pulmonary arteries. They are big, they are plumb, they're larger than the surrounding aorta. And we're wondering, like, why? Why is that? So that's a lot of hypoxemic stress on the lung for your pulmonary vessels to be that plump and big. And that has become a really important marker now. Low-hanging fruit. Why? Because anybody who's got interstitial lung disease is going to get imaging. So you don't really have to wait for echo or cardiac examination and delay the diagnosis, but you can shift your gaze from the lungs, little to the center, and get these extra pieces of information, which we now know are extremely important in determining whether this patient has pulmonary hypertension. Next slide, please. So as I alluded, again, I want you to focus on that cartoon or the cut of this CAT scan on the upper left corner. And you can see a line which I've drawn through the pulmonary vessels. And that line, if you draw through the adjacent aorta, is larger. So this pulmonary vessel is diameter is larger than that of aorta. And this is how we find out. And it is not any kind of a major technique. It's a very simple technique that you come down to the level where you can see pulmonary artery and you compare with the aorta. Even a medical student can do that. And you can see that the pulmonary vessel is way too plump, way too big than the aorta, and something is not. So the studies have shown that in patients who have this pulmonary vessel, which is larger than aorta, these patients have a much higher mortality rate. So just having a ratio of more than 1, which means even a slight increase in the size of pulmonary vessel over the aorta, translates to a much poorer prognosis. It also translates to a very high prevalence of pulmonary hypertension. So it's become a surrogate marker to determine pulmonary hypertension even before you send for echo, before you send for cardiac evaluation. So simple tool. Next slide, please. And this is another test called the brain natriuretic peptide, or the BNP, or pro-BNP, some people call it, available in every hospital. You could go to even a critical access small hospital, and this is just a small 2 cc syringe of blood done, and a BNP, which is going to be back within a couple of hours. And it has been equally well correlated with pulmonary hypertension. So remember, if the patient has interstitial lung disease but no pulmonary hypertension, there is almost zero chance of your BNP being elevated. So if your BNP is elevated in a patient who's got interstitial lung disease, then you need to start thinking about pulmonary hypertension being a concomitant comorbidity in these patients. So I just told you about 2 simple tools. One is just a visual examination of a CAT scan, which has already been done. You don't have to do a step further. And the second is you send that patient downstairs or wherever your lab is, and in 2 hours, you'll get a BNP level. Both of these important surrogate markers that there's something more brewing up in that person with interstitial lung disease than meets the eye. Next. All right. Now, you would say, and I wouldn't object, because I think that was my first reaction when I saw this data, was that, hey, that means that if your interstitial lung disease, which is scarring of your lungs, continues to get worse, then the pulmonary hypertension would get worse. Okay, or maybe I'm putting the horse behind the cart, is that if your pulmonary hypertension is very high, then maybe I have to assume that the interstitial lung disease is pretty advanced at the same time. Not true. Okay, so several studies, and this is one done again in Washington, D.C., showed that majority of these patients actually had pulmonary hypertension, had mild form of interstitial lung disease. The thought process was that maybe that these severe patients never made it to the point of diagnosing pulmonary hypertension, and these people had a bad outcome and died. And so what we do see is that that interstitial lung disease, even mild form, is associated with pulmonary hypertension. The moral of the story is that just because somebody has mild disease, you shouldn't be saying he cannot have pulmonary hypertension. Pulmonary hypertension should be looked nowadays, as of today, in every patient who has interstitial lung disease, or an entertainment of that diagnosis is being made. It's a very important aspect of evaluation of interstitial lung disease, no matter it is mild, moderate, or severe, should include pulmonary hypertension evaluation. Next slide, please. So again, coming back to my main theme of this lecture, that all the road to hell is paved with normal echoes, which basically means that we no longer can trust echoes as our main source of diagnosing or screening for pulmonary hypertension. And this is, again, work done by Steve Nathan at Inova Fairfax Hospital in Falls Church near Washington, D.C. And what they basically showed was that 1/3 of patients who had an echo and the RVSP was not indicative of pulmonary hypertension reportedly had pulmonary hypertension when a gold standard right heart catheterization was done. So almost 1/3 of patients were missed by this echo. So not a happy situation for a group of people whose mortality and outcome depends on this measure. Next slide, please. So what do I need to do a right heart cath? Absolutely. Every patient who you suspect of having a pulmonary hypertension, whether it's ILD or in the non-ILD, needs these days a right heart catheterization for gold standard diagnosis of hemodynamics. There are a lot of nuances in pulmonary hypertension, as I initially alluded to you, that there are 5 groups of pulmonary hypertension, and you cannot afford to misclassify them because the treatments are different for each group. And some of these medications that FDA approved for group 3 may actually be harmful in other if used in context of other groups. So right heart catheterization, ensuring that you classify these patients appropriately, having the hemodynamics data is essential for next step. Next slide, please. So again, based on all the data that we have accumulated about the fatality of this condition with or without ILD, the 6th World Symposium Pulmonary Hypertension recently changed the definition to the mean PA pressure of 20 instead of 25, and they reduced the PVR cutoff from 3 Wood units to 2 Wood units, again to facilitate early diagnosis of this fatal condition, so that people can identify that this disease early. And early disease in many studies have shown to have a better outcome on intervention than when you find it out too late in the process. Next slide, please. PVR, as I had earlier alluded, is an important aspect of the diagnosis of pulmonary hypertension. And this is a study done on interstitial lung disease, the topic of today. And you can see that higher the PVR, the more the death in this group. So it can also not only diagnose, but also prognosticate patients. So anybody with PVR of more than 6 has a much higher mortality rate as per the studies. Next slide, please. So I think the next question you're going to ask is, okay, fine. We spend half an hour trying to define a disease and say how bad it is, but what can we do about it? I mean, that's the final crux. I can identify a problem, but, I get stuck as to what do you do with this when you get to that fork in the road. So next slide, please. So fortunately, we have had some advances in there. Now, you must be saying that, well, this is something new, so something dramatic must have happened in the last couple of years. But, these things don't happen overnight. This is whole 20 years of data. And I think a very, very frustrating era for us in the world of pulmonary hypertension and interstitial lung disease. This is the graveyard of all the failed studies of the last 20 years. Showing that none of the treatment modalities FDA approved for the group 1 was anywhere effective for patients with interstitial lung disease. So if so many of these studies have failed, why would another one study be useful? Or how would it even change the landscape when 20 are telling you that it doesn't? Well, one of the thought processes we had, and this was not new, is that, listen, these people have lung disease. Their lungs are getting scarred. So if you give very strong systemic pulmonary vasodilators to them through either IV or orally, they're going to have a big shift in their pulmonary vasculature, which we call a steal phenomena, because one of the ways a bad scarring lung compensates is by increasing the flow of pulmonary vessels to areas of the lungs which are better ventilated, which means if a part of the lung has a better oxygen supply, that's where all the blood is going to come in, because the body wants to do its best to oxygenate all the organs. That's the whole idea of the pulmonary vasculature. So if we give systemic vasodilators and we vasodilate the entire pulmonary vasculature indiscriminately, that's going to lead to a bad outcome, because that's bypassing the body's mechanism to facilitate that particular mechanism. So we thought maybe it's better to give the medication delivery through the lungs, because the lungs know better. They're going to take the drug to that area of the lung where there's better oxygenation. And where there's better oxygenation and ventilation, there is better perfusion. So there's more blood flowing in that direction. So we're going to be matching the two people who need to meet, which is the blood and the oxygen, instead of carpet bombing and dilating all vessels and then causing a mismatch, which I thought these medications were doing. So this is the kind of background against which we were working for the last 20 years. Next slide, please. And then this study came in. So this is the first study, but again by Stephen Nathan and his group in Washington, D.C., published in New England Journal. They used the same technique. They use inhaled medication, treprostinil, in patients with pulmonary hypertension with interstitial lung disease. And next slide, please. And lo and behold, for the first time, they found that they could actually make a difference. So this is the increased studies demographics. You can see age were around 60 to 65. You had equal number of men and women in the study. The etiology or the reason for their lungs getting scarred was pretty variable. You can see from idiopathic to CPFE, CTLD. You may want to keep this thought on of CPFE. We're going to come back to combined pulmonary fibrosis and emphysema part a little bit later on and touch base about some of the nuances in that. But you can see that there was a pretty variable crowd and mixture of several etiologies. Next slide, please. So what they found basically was traditionally in the pulmonary hypertension world, when a disease or the drug is tested, it is tested as to how much the person can walk further after the medication is given in a randomized controlled trial. We call it the functional capacity, and the way we measure that is called the 6-minute walk test, which means how much can the person cover a distance in 6-minute walks if given an opportunity. So you can see here in a randomized controlled trial, there was about 31-meter difference between the two groups. For people who are not familiar with this research, we'll say what is the 31-meter difference is not much. And I would agree with you, it is not much for a person who is very short of breath, who can barely make it from one room to another and has trouble going to the washroom or doing his ADLs. 31 meter is a long time, the long distance. He can actually go and do some grocery shopping, with this. So it's all relative when you're talking about really, really sick people. So in our world, this is considered significant, and that's what they showed for the first time, that these patients may be benefiting from this medication. Next slide, please. So when they looked at more detail as to who are the people who are most benefiting, Surprisingly, the people who benefited more, even than what I showed in the last slide, were the ones who were much sicker, higher PVR, worst 6-minute walk test, lower diffusion connective tissue disorder, and people who had underlying connective tissue disorder as the cause for the interstitial lung disease. So sicker you are, the more you benefit from this medication. Next slide. Thank you. So now we didn't have any hemodynamics data. By hemodynamics data, I mean going inside the heart and saying, hey, are the pressures coming down? Just like you said, that this medication is going to lower down the pulmonary pressure. But we have a surrogate marker. Remember, we talked about the proBNP. ProBNP is a marker of how much the heart is under pressure. The more the heart is under pressure, the more it's going to release BNP in the blood and you can capture it. The less the heart is under stress, the less it's going to release this hormone. So they tested this hormone before and after the medication in these patients who were randomized to treatment versus non-treatment in the trial. And they found that there was significant reduction in the PNP in the treatment group. That means, or at least the evidence suggested, that the heart must be relaxing for this enzymes to either go down and disappear. But in the group which was not treated or was in the placebo, it continued to go up with the BNP, suggesting that those patients had no freedom from this excessive stretch and pressure inside the heart. Next slide, please. So based on this data, the FDA approved inhaled Tyvaso for these patients in April of 2021. And I think earlier this year, Medicare or CMS also approved this medication for the elderly. So this is up and running. Unfortunately, a lot of people don't know about it. So a lot of these patients with interstitial lung disease, people never think about it. It's so brand new. So I thought this would be something which would be important to disseminate this information, that this is out there. Not only we understand the physiology as I walked you through that, but we have a treatment option for these patients who already are devastated by interstitial lung disease, but now have a much higher mortality if they have a concomitant pulmonary hypertension. So having said that, we go to the next slide, please. So just alluding a few concerns. Of course, one study, one trial, you know, as physicians, we are always skeptical about anything which is just solo hanging out there. You know, we obviously looked into it much deeper. You know, this study was scrutinized at different levels. And one of the things which we found was that there were a lot of people that had combined pulmonary fibrosis and emphysema. What is that? Well, this is like your lung is scarring and also getting hit by a cigarette smoking disease called COPD. So it's like a double whammy. Why is that important? It's important for a state like West Virginia, where not only have interstitial lung disease, but is the highest smoking state in the entire country. So we have a large population of combined pulmonary fibrosis and emphysema. And this was one group which did not benefit from this medication. So remember that any study which you're alluding, you have to understand the nuances of the study as to which group will benefit and which will not benefit, which are the subset of people which may benefit, which may not benefit. And we were concerned that maybe West Virginia, having a large population of CPFE, and I'll show you a slide subsequent to this, you know, how are they going to impact? I mean, these are national data, but they are local variations. You know, you just can't take a data from New York and then apply it to West Virginia. It won't work. We showed that in COVID. I think I alluded to my study last year on how COVID was different here in West Virginia as in New York, and how we needed to change our approach. Next slide, please. So going back to, you know, make this point even more clear, that the same group which did the successful study in Washington, D.C., had earlier studied a drug called rioxyguat, which is a pill, again for pulmonary hypertension, in the same situation of interstitial lung disease. And guess what happened in that study? That study had to be prematurely terminated. And it was prematurely terminated because the board determined the people who were getting the medication were dying more than the people who did not in the placebo arm. So they had to take an executive decision, say you cannot continue with this study. You got to stop the study right now. So as scientists, we have to look at the holistic data, not just one study. So we looked at it from this perspective and say, hey, this study was stopped and nobody's talking about it. So next slide, please. So what was wrong? I think to go to the credit of the authors of this, they just didn't stop the study. They looked into the reason as to why this even happened. And they found out, if you look at the crosses on the bars right now, the patients who died were the ones who had CPFE, combined pulmonary fibrosis and emphysema. So these were the group or subset of people who were dragging the entire study. So we knew that this is a separate entity. This is something which we need to be very careful about. Next slide, please. Now, coming back, why is it important to us? Well, in the Appalachian region, in the West Virginia region, we have the highest prevalence of smoking. What does that mean? We probably have high level of CPF. We have a highest prevalence of COPD in the United States. We have the highest death due to pneumoconiosis or cold-minus disease. So this is a whole new different world that we're living in, and we have to account for these changes rather than blindly follow the data which may be released, sometimes not taking into account our local variations. Next slide, please. To hit the point even further home, this is our own study done in West Virginia, where we looked at what is the prevalence of combined pulmonary fibrosis and emphysema and the role of cigarette smoke in pulmonary hypertension. We found out there was 45% of the patients with interstitial lung disease, almost half of the patients who were deemed as interstitial lung disease before actually had CPFE or combined pulmonary fibrosis and emphysema. So that kind of gives us a pause as to maybe we should hold our horses, not get too excited, and take it day by day and look at these patients very carefully. I'm not dismissing any of the big trials that we just alluded to, mentioned to, and all the good things that can happen. What we're basically saying is, hey, our health depends on our own hands, and we need to be more careful. We need to take local factors into situation. And if nothing, at least be cognizant that there are factors playing into West Virginia's dynamics, which may or may be different than what may be playing in Washington, D.C. Next slide, please. So based on that, we have started a big clinical program and trial here at Ruby, looking at pulmonary hypertension due to interstitial lung disease in rural Appalachia. So what we do is basically we classify all of these and we very carefully look at the subsegment of CPFE. And what we are doing is doing a study instead of combining the way they did for that. We are segregating and seeing which group really is benefiting and which group may be getting hurt by that. So we can redefine the treatment of this process, at least from West Virginia perspective or Appalachian perspective. Next slide, please. So bottom line, I wanted to ensure was that, you are aware of some of the nuances which we talked about in this whole case series and the recent advances. And one of them was that it is not as simple as it sounds when somebody comes with a sound bite to you, hey, new treatment available for PH-ILD is going to save lives. Well, you got to hold your breath for a second and say, does that apply to me? does that apply to my population? Okay, if does not, then what are the nuances? And then if there are nuances, then how do I deal with those nuances? So that's one way. And one way to do that is to refer to this kind of a ILD program. So what we have done here is we have combined our strengths in pulmonary hypertension with a group of ILD specific experts. So this clinic is not run singularly by this or that. It's a combined expertise where there's a dance of scientific information, push, pull, and saying why this should be done and why this shouldn't be done and why am I against it and what are the scientific reasons should be done. And then classifying and watching them over time period of time. Next slide, please. The next take-home message is that I think we had put a lot of money on echocardiogram. I see that all the time in my practice. Well, I don't think he has pulmonary hypertension, and I think he's okay because I got an echo done and it was normal. As I said, the road to hell is paved with normal echoes. We don't trust that anymore. So if you really think, and if you really look at the data, and you see that 80% of them may have underlying, I would say rather err on the side that you have the disease rather than not, because you can do something about it. What are some of the low-hanging fruits instead? PA to aorta ratio. There is not a single person with interstitial lung disease who will not have a CAT scan. But that's how the first step in the evaluation of ILD happens. Okay, so you don't have to wait for months for echo to come back. You don't have to wonder whether this echo 3 months down the road is valid or not. Is it showing what it needs to show or not? You could have the PA aorta ratio, and if it is more than 1, hey, something is not right in the chest. BNP is a $20 test. Not a hospital, not a clinic in West Virginia, which can't draw a simple blood test and show you that the BNP is elevated. Anybody with interstitial lung disease has a PFT done, and you see DLCO, or diffusion lung capacity less than 40. You need to ask yourself, why is it so low? Why can't the oxygen transfer from the lung to the blood not happen in these patients? So these are 3 very simple ways, without waiting, without wasting too many taxpayer dollars, that you can make decisions right there in the clinic at that same time. And then we are happy to help you make further decision whether this patient is going to benefit from these near FDA-approved treatments or not. And these are some of the information, the phone numbers, fax numbers. You can even email me directly. Mitra can share my contact information. But with this, I wanted to thank you for your attention, and I'll be happy to take any questions. Thank you.
Thank you so much, Dr. Sharma. Always a wonderful presentation by you and so much great data. And we really appreciate you for that. Opening it up for any questions, comments from the group. Everyone is welcome to unmute and chime in or chat in the chat box, and I'm happy to read it out loud. So. We had some more folks hop on here as you went through your didactics, so I'm happy the rest of you could join. Hey, Dr. Stansbury.
I guess a question would be, it almost seems like all of these patients should be evaluated for pulmonary hypertension. You know, can't trust the echo. 80%, I think you said, have comorbid PH. And, I guess when you're thinking through this, where do you draw that line? If the PA artery to aorta is kind of borderline, just continue to monitor. If it's normal, just say it's unlikely they have it, or because on the one hand, you can almost overrun the clinic. And I think something else to comment on, which people struggle with a lot, so many times in West Virginia, we have someone who's morbidly obese with sleep apnea, diastolic heart failure, comorbid COPD, and an elevated PA. And we say PA pressure that you find on echo. And we say, optimize the heart failure, optimize the OSA, lose weight, COPD. Is there any role for a pH evaluation in those patients?
Yeah, excellent question, Rob. And I think to reiterate to the group, the part A of the question, should everybody be evaluated? I think we should just keep that in the front of our brains, that this is a entity which is very important, can contribute to mortality. But if you look at the nuances of it, when I say 80% prevalence, it's mostly in patients undergoing lung transplant on the cath done before. So by the time you are entering the lung transplant phase of ILD, I'm assuming most of them will have pulmonary hypertension. But that may not be true in the beginning or the early aspects of that. So I don't think everybody needs to be evaluated. But the other thing is that of the limited experience, we started this program of ILD pH about 6 to 8 months ago. And what we have learned is that 60% of the people will have group 1, but as Rob alluded, that 40% other will have other groups playing a role, like group 2 is an important one. Severe sleep apnea, underlying severe hypoxemia secondary to that, or underlying obesity hyperventilation syndrome causing hypercapnia were contributing to the others. So as I said, it's very important to dichotomize and reclassify this pulmonary hypertension. So anytime I say pulmonary hypertension, it's a generic term, the umbrella term I'm using. It doesn't mean that every pH has to be treated. You have to classify, and the only people who would qualify for treatment with inhaled Tyvaso would be the group 3 pH ILD, which are falling in group 3, but have group 1 physiology on cath. So that's a very tiny segment of it. And I wouldn't say not a tiny, but 60% is what our data is showing, the limited data. As the study goes by, I'll be happy to come back and, educate the group again as to what our findings were. But I think these are the nuances. You got to classify, you got to look at other diseases maybe contributing to pulmonary hypertension and obesity hyperventilation syndrome, OSA, obesity, everything, all of those become important because they can contribute to diastolic heart failure, and that can then cause group 2 physiology of pulmonary hypertension.
Thank you very much, Dr. Sharma and Dr. Stansbury, for that comment and question. Any other thoughts from the group or questions? And as always, I will be sharing the slides, Dr. Sharma, in the recap email, so everyone will be getting a copy of those, even the folks who were able to join live during the session as well.
Well, thank you for having me, and I always enjoy talking to this group.
And we always enjoy having you on here as well. Thank you so much. I only have one announcement, and that is our next session is on December 19th. And Dr. David Weissman actually will be presenting on lung cancer screening. So we look forward to seeing you all again next time. Stay warm and have a great week. Stumbling on my words, it's early. All right, thank you everyone. Take care.
Yeah.
Bye.